بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. First of all, I want to thank the organizing committee for inviting me to share this session. It is very interesting to be here for the first time to be in virtual meeting. So it's my all pleasure to introduce our first speaker in this session. Where sulfonylurea fit in type 2 diabetes management. It will be presented by Dr. Nasser Al-Jihani. Dr. Nasser Al-Jihani is an endocrinology consultant. He is the head of the endocrine department at East Jeddah Hospital. And he will give us a talk about where sulfonylurea fit in type 2 diabetes management. Dr. Nasser, the floor.
Thank you, Dr. Omar, for this introduction. First of all, I want to thank the organizing committee for this virtual meeting. Do you hear me very well? Yeah. So today we'll talk about where does sulfonylurea fit in the type 2 diabetes management. Okay, it is old medication. This is the agenda. Does we still need sulfonylurea in clinical practice? Is the glycemic efficacy is important? Is modern sulfonylurea is different from old sulfonylurea regarding hypoglycemia, weight gain, cardiovascular safety? Where is the position of sulfonylurea in the current guidelines? And what's the cost of sulfonylurea compared with the other medications? Some people, they think that sulfonylurea is needed because there is long experience. I think 99.9% of us, they don't reach the age of 70 years, and still now they see virtual meeting. So is the experience with sulfonylurea is more than the age of all of us here in this group probably. We need more options because one of the main physiological defect in type 2 diabetes is defect in insulin secretion. It is very efficacious medication. It is low cost. This medication is widely available. Really, in real world evidence studies showed low incidence of hypoglycemia. There is no cardiovascular risk, especially with the new sulfonylurea, and it is the drug of choice in mode 3 and in neonatal diabetes. As we said, sulfonylurea, very old drugs. It is almost 70 years old drug. This is the first generation. It is not available now, the first generation sulfonylurea, chloropropamide, tolubutamide, tolazepamide. This is not available. Second generation sulfonylurea, glibenclamide or glyburide, USA, also is limited to the age below 60 years. And the available now second generation sulfonylurea, gliclazide, glibizide, or third generation sulfonylurea, glimepiride, gliclazide MR, and the glibizide XL. So the most commonly used sulfonylurea now is modern sulfonylurea, that it is gliclazide, glibizide, and glimepiride. Efficacy, since the past decades, more than now, maybe around 20 years ago, although there is a lot of medications, okay, discovered in the field of the management of type 2 diabetes, really there is no improvement in the glycemic target. Okay, so almost 50% of the patient, they don't reach the glycemic target since the past decade, although there is available many options. If you can see sulfonylurea here, one of the strongest medication, if you can see gliclazide, glimepiride. This is not head-to-head comparison, but if you compare with DPP-4 inhibitor or selective glucose transporter, most of the studies showed that sulfonylurea is highly efficacious medication, and DPP-4 inhibitor and selective glucose transporters, they are intermediate efficacy. This is the efficacy of most of the sulfonylurea. They decrease hemoglobin A1C as monotherapy from 1 to 2%. It is potent drugs. If you can see, this is the RCT trials for the cardiovascular data. These drugs, either selective glucose transporter or GLP-1 receptor agonist. If you can see here, most of these recent trials, Baseline sulfonylurea constitute 30 to 40%, up to 50%. And here also, in the other trials. So most of the trials regarding selective glucose transporter, like leader studies, exenatide or Harmony studies, or Pioneer for oral semaglutide, or IMBA, or CANA, or DECLARE study, they use sulfonylurea as a baseline in 30 to 50%. So it is commonly used drug in clinical practice. This is study done in Saudi Arabia and published in January 2020 by Dr. Rubayhan. They found almost 90% of the patient, they are in metformin, and the second medication after metformin for around 600 patients in this study is sitagliptin, then followed by sulfonylurea gliclazide in around 35%. So you can see now it is commonly used drug either in Saudi Arabia or all over the world. So from 30 to 50% of the type 2 diabetes, they are in sulfonylurea all over the world. If you can see the price here, sulfonylurea, the price is almost 6 to 7-fold as much less compared to GLP-1 receptor agonist or compared to selective glucose transporter or DPP-4 inhibitors. So sometimes the cost for some patients is very important. So gliclazide costs almost 21 Saudi riyals, but if you go to the Janofia 122, and if you go to Daba, gliflozin around 138. This is data 2017. So 80% of people living with diabetes in the world, either in low or intermediate, okay, income population all over the world. So sulfonylurea probably needed. If you go to China, if you go to Pakistan, if you go to the other countries, really they are low to middle income, so they need cheap medications. Some people, they are against sulfonylurea, okay, they think it is not needed. The reason because if there is increased hypoglycemia in RCT trials, meta-analysis showed probable excess mainly with old sulfonylurea. This is cardiovascular risk mainly with old one, chloropropamide, but probably not with the new. And the effect is not durable, may exhaust the pancreas, but also this probably with old sulfonylurea. And the modern drugs like GLP-1, some of GLP-1 receptor agonists, selective glucose transporter, showed some improvement regarding cardiovascular endpoints. So if you go to the hypoglycemia, this is the meta-analysis, okay, published in 2017. They found that gliclazide has the lowest risk of hypoglycemia, then followed by glimepiride, then glipizide compared to gliclamide. So from this network meta-analysis that include more than 16,000 patients with type 2 diabetes, they found that the second or third generation sulfonylurea, they have much lower risk of hypoglycemia compared to the other medications. Regarding the place in the American Diabetes Association or European Association of Study of Diabetes 2018, glipizide or glyburide in USA, in Canada called, has much higher risk of hypoglycemia compared to the new sulfonylurea. Glipizide, glimepiride, gliclazide, they have low risk of hypoglycemia. So the new generation sulfonylurea, especially in real-world studies, seem to have low risk of hypoglycemia. Regarding the cardiovascular data, this we know that mainly control hyperglycemia in type 2 diabetes. It improves microvascular complication, mainly retinopathy and nephropathy. But if you can see in Nucleopedes study, if you control diabetes early on in the course of type 2 diabetes, you may prevent cardiovascular complication on long-term run. This study, epidemiological studies published in New England Journal of Medicine in 2018, they found that poor glycemic control is the most important risk factor for cardiovascular disease in type 2 diabetes. So poor glycemic control is related to myocardial infarction, is related to stroke, then followed by systolic blood pressure, then followed by LDL cholesterol, then followed by physical activity, then smoking. So glycemic control, one of the important factors if you go on long-term run, that may be important if you control early in the prevention of macrovascular disease and type 2 diabetes. This is also meta-analysis for 18 studies, included 1,670,000 patients. The death in this meta-analysis was almost 15,000. They found that glyclazide and glimepiride and glipizide, they have lower risk of mortality compared to glipniclamide. So if you take glipniclamide or dawanil as a baseline medication, you will find the glyclazide, the glimepiride, they have lower risk for mortality compared to the old sulfonylurea. This is Carolina study, showed that if you compare linagliptin with the glimepiride, both of them, they have similar cardiovascular adverse effect. So almost sulfonylurea is comparable for DPP-4 inhibitors regarding cardiovascular effects. So really, there is no increase in all-cause mortality compared to active treatment for the sulfonylurea or new generations of the sulfonylurea. In real-world studies, sulfonylurea either showed minimal weight loss, around 1 to 2 kg, or really neutral weight loss, especially with the third-generation sulfonylurea, like a glyclazide. So the best combination with sulfonylurea, probably with selective glucose transporter, there is no increased risk of hypoglycemia. There is greater weight loss. We know that if you combine sulfonylurea with DPP-4 inhibitor or with GLP-1 receptor agonist, there is increased risk of hypoglycemia. So probably you need to decrease the dose of sulfonylurea and be careful about the risk of hypoglycemia if you combine sulfonylurea with DPP-4 inhibitors or GLP-1 receptor agonist. This study, they compare glipniclamide, 168 patients, they followed for 8 years, and glyclazide MR. They found that there is less exhaustion of the pancreas with the glyclazide compared to glipniclamide. So at 14 years, the hemoglobin A1C remained within the target 6.8. At 8 years, the hemoglobin A1C increased to 7.4. So probably the new sulfonylurea may they exhaust or stimulate the pancreas less than the old one. So what's the position in the current guidelines? If you go to the International Diabetes Federation guidelines, usually they are concerned about the cost of medication. You will find sulfonylurea as in a place of metformin if the patient is intolerant to metformin, or as a second line if the metformin is failed. So in International Diabetes Federation 2017, sulfonylurea either can be used as a primary or as secondary or second medication after metformin. If you go to the WHO organization, they recommend that sulfonylurea to be the second medication to control type 2 diabetes after metformin, and they limit glipniclamide to patients below the age of 60 years. And they recommend the new sulfonylurea like glyclazide or glimepiride. If you go to NICE guidelines, sulfonylurea in 2017 can be used as second option or third options or fourth options. Selective glucose transporter can be given as monotherapy or can be given as dual therapy instead of DPP-4 or if sulfonylurea or biglutazone is not appropriate. What's about American Diabetes Association guidelines updates? This is the American Diabetes Guidelines Update 2020. They recommend first you should classify the patient either they have established cardiovascular disease or chronic kidney disease. If the patient already has established cardiovascular disease or chronic kidney disease, better to use selective glucose transporter 2 inhibitors or GLP-1 receptor agonist. If the patient doesn't have cardiovascular disease or established cardiovascular disease, or the patient doesn't have a chronic diabetic kidney disease, you can use other medications. If there is risk of hypoglycemia, you can use selective glucose transporter or GLP-1 receptor agonist. If you are concerned about the cost, you can use sulfonylurea or basal insulin. If you are concerned about the weight, you can use selective glucose transporter or GLP-1 receptor agonist. If you look for the patient, in diabetic patient that they have cardiovascular disease, almost 2/3 of the patient, they don't have either no cardiovascular disease or no chronic kidney disease. So almost 1/3 of type 2 diabetic patients, they can have cardiovascular disease and they are candidate for GLP-1 receptor agonist or selective glucose transporter. So most of the patients, they will not have. If you go to primary health care, lower patient, they have established cardiovascular disease. If you go to the tertiary hospitals, probably more patients, they will have established cardiovascular disease. So here in this study, 15% of the patient, they have chronic kidney disease, 13% of the patient, they have cardiovascular disease, 9%, they have both cardiovascular and chronic kidney disease. If you look for the studies or meta-analysis in 2018, in the Middle East and North America, almost 26% of the patients, they have cardiovascular disease. So almost 2/3 of diabetic patients, they don't have established cardiovascular disease, so they are still candidate to use other medication like sulfonylurea, like DPP-4 inhibitors. We know that selective glucose transporter is beneficial drugs, but probably the cost is the main issue with these medications. So if they have patient with established cardiovascular disease, better to use GLP-1 receptor agonist or selective glucose transporter. If you have patient with heart failure, ejection fraction less than 45, or you have a chronic kidney disease with estimated glomerular filtration rate from 30 to 60, or there is albuminuria, the best is to use selective glucose transporter. If the hypoglycemia is an issue, you can use selective glucose transporter, TZD, DPP-4 inhibitor, or GLP-1 receptor agonist. If you have weight gain is main issue you can use selective glucose transporter inhibitors, you can use GLP-1 receptor agonist. If the cost is the main issue. We know that American guidelines, not like UK guidelines, not like IDF guidelines, always they look for the cost. So usually they use expensive medication. UK guidelines, actually, they look for the cost and they prefer to use low-cost medication, like, for example, basal insulin. They encourage using low-cost medications, and they don't mandate to use the other medication, but usually they encourage. IDF guidelines, they look for low and intermediate income countries, and usually they encourage sulfonylurea, especially second and third generation sulfonylurea for treatment of type 2 diabetes after metformin. If this fails, you can use other medications. This is the consensus recommendation of sulfonylurea. This is in the South Asia guideline. This is published in the Indian Journal of Endocrinology and Metabolism.
2000. 2 minutes.
Yes, is about to finish. This is the last slide. Thank you for it. So if you look for the world, look for China, look for the India. If you look for China, for example, they constitute quarter of the world. So usually they use low or cheap medication like sulfonylurea. So sulfonylurea is still widely used medications. In Arab countries, because this is a little bit rich countries, they may few patients or less compared to the other part of the world, they use sulfonylurea. Regarding the safest sulfonylurea in a chronic kidney disease, glipizide, I didn't mention it here. It is available, but probably it's not available in all the hospital. It is not available in much hospital. In our Ministry of Health hospital, we have a gliclazide, short acting. We have a gliclazide XR or dimicron. You can use it in stage 4 to 5 renal disease, but be careful. You start with the smallest dose and be careful. Usually, the short acting is preferable if the glomerular filtration rate or stage 4 chronic kidney disease or 5. Preferable to use short acting because of risk of hypoglycemia and use the smallest dose. If the glomerular filtration rate above 30, from 3 and above, you can use the gliclazide. Glibenclamide is contraindicated if the glomerular filtration rate below 60. Glimepiride, you can use it if the glomerular filtration rate above 30. Better to avoid it if the glomerular filtration rate below 30. And the safest sulfonylurea in a chronic kidney disease is glipizide. And usually you start with small dose. Thank you for you. And this is the last. I finished. Thank you, Dr. Omar.
Okay, thank you. MashaAllah. Alhamdulillah, we are good in time and we have 5 minutes in advance. So thank you, Dr. Nasser, for this excellent presentation, which is describe the role of sulfonylurea in the type 2 management. Now let's move to our next speaker. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Nasser, for this excellent presentation. Now we'll move to our second speaker, Dr. Raed Al-Dahash. He's an endocrinology consultant at the Division of Endocrinology, Department of Medicine at National Guard Hospital in Riyadh. Also, he's the head of Endocrine Division in National Guard Hospital, Riyadh. He's also assistant clinical professor in King Saud bin Abdulaziz for Health Science University. Dr. Raed will give us a talk about early treatment in type 2 diabetes in clinical practice. So, Dr. Raed.
Yeah, thank you, Dr. Omar, for your introduction. I think the slide is clear for you.
Yes.
You see, yeah. Oh, okay. Okay, so I will talk today about early treatment of type 2 diabetes. So, as you know, I will start with the burden of diabetes in general. So this is the diabetes prevalence worldwide. As you know, in the world, the diabetes is increasing everywhere and anywhere. So this is the comparing many countries with each others. So in worldwide, in 2012, in IDF, it's showing 462 millions, and expected in 2045 it will reaching 700 millions. Also in everywhere like South America, North America, and European country. But the problem is in Middle East, the increasing it will be higher. It's almost 100% if we compare it worldwide. Here is 50%, and here is almost 100% doubling. So in 2019, we are having 55 million, but in 2045, we are expecting to be 108 million. What about Saudi Arabia? Saudi Arabia, this is a study by Dr. Arbian and his group. This is talking about if we add pre-diabetes to diabetes, what's the percentage of having patients? This study, they talking about those patients, their age 30 or above. So if we add pre-diabetes to diabetes, the percentage, it will be more than 50%, which is a huge percentage of diabetes or pre-diabetes. We ask ourselves always, why we having this problem in Saudi Arabia? And we try to figure out what's going on. Could be this is one of the causes, our social habits, our social foods. Sometimes we having our habits in some of countries, Saudi Arabia. Sometimes they put a dates with the rice and with the chickens or meat. This is very high carb meals. So what about the cost of diabetes? If we talk about the cost, diabetes is associated with many complications, contributed mortality and healthcare cost. This is the US figures. So worldwide in 2012, 3.7 million the cost. Annual cost in US dollars is 827 billion. What about, okay, now it's, now it's okay? Yeah, okay. So health expenditure from 6 to 17 of total health expenditure, and there is a project rise in expenditure about 7%. What about Saudi Arabia figures? The cost of Saudi Arabia in diabetes in 2014, overall 17 billion riyals. But if we talking about untreated or early stage, which is our lecture today, it's almost we having 10% here untreated and another 10% in early stage. But because we missing this part, the cost having 17 million. If we invest more in prevention and more in treatment, maybe we have less cost of treating diabetes in Kingdom Saudi Arabia. Because if we don't treat it in early stage, there is a progression, then the complication, then dialysis, then transplant, and so on. As you know, the pathophysiology of type 2 diabetes, either impaired insulin secretion, increased hepatic glucose production, impaired appetite regulation, decreased glucose uptake, or increase glucagon secretion, decrease incretin effect, increase lipolysis, or increase glucose reabsorption. So usually the progression of diabetes starting about insulin resistant, then after that the insulin level start to be compensated, then coming down. Then after that the beta cell functioning, maybe before of diagnosis. Here this cut is the diagnosis of diabetes, so the beta cell functioning start to be decreased before the diagnosis. Then after that hepatic glucose production, then postprandial glucose and fasting blood glucose is increasing. What about complication? Usually the microvascular and macrovascular complications starting before the diagnosis in all and most of our patients. Here maybe the prediabetes and impaired glucose tolerance. Usually we should having earlier approach intervention. It might improve the chance of reaching hemoglobin A1C goals. Usually when we start to diagnose the diabetes, when hemoglobin A1C 8.5 or more, we start with monotherapy. Then after that, we start to having, when there is no response or there is increase in hemoglobin A1C, we start with double therapy. Then after that, the triple therapy. Then in the later stage, we starting with insulins. And there is delayed in treatment and delayed in management. If we starting in other way around, for example, this is, we will start diet, this is monotherapy, this is double therapy, this is the combination therapy, and this is the basal insulins. How we start in other way around, for example, we start with very comprehensive diet. Then after that, if we're reaching 7, then we add a second combination therapy, then we're going up third, then basal insulins, then after that, maybe basal bolus. So earlier intervention, we make the patient always in the safer stage and make the patient always in the target stage. So this is a graph to show you that immediate treatment intensification, it will improve the glucose control. This is immediate intensification. It will decrease hemoglobin A1C about minus 1.1. But if we delay it, the hemoglobin A1C, maybe it's difficult to be controlled. This is comparing how much patient reaching the goals with hemoglobin A1C less than 7, immediate intensification versus delayed intensifications. 45%, they reaching with early intensification, hemoglobin A1C in the target. If we compare it with 19.1% in delayed intensification. Usually we ask ourselves, we are only in Saudi Arabia, we don't reaching our goals, or it's worldwide problem? Actually, it's worldwide problem. And most of the patients with diabetes, they're not reaching their goals. Here, for example, this is the US. 49% only of the 49% of the patients, they don't reaching their goals. Here, Brazil, here, France, Germany, and Italy, and so on. Many countries in the world, they don't reaching their goals, not only in Saudi Arabia. So delayed in the treatment intensification, despite of suboptimal glucose control is common. So there is time to treat and there is time to reaching our intensifications. Here we try to compare those intensified with oral or insulins versus those with not intensified with oral only. Here, when the hemoglobin A1C more than 7, we spend 2.9 to intensify per year, almost 3 years to intensify with oral medication. But if we adding insulins, it's reaching up to 2 years. If hemoglobin A1C more than 7.5, usually our trigger to intensification is more, so it will be decreasing to almost 2 years with oral, but with insulins maybe 1.5. And again, if more than 8, our intensification, it will be higher. So for example, we're reaching 1.6 versus 1.8 with oral or insulins, if we add insulins also. So the percentage of patients that intensified in each stage here, it's around from 65% till 76. More higher in hemoglobin A1C, more the desire of the physician to start more intensification of treatment. What about if we are delaying in the treatment, or if we are delaying intensification? Usually the complications start to be, this is the graph showing that patient with retinopathy. The retinopathy usually starting progression if we don't start early intensification. This study was done in Thailand and showing there is more progression in diabetes retinopathy. However, the complication usually started not only when we are diagnosing diabetes, it's starting when we having pre-diabetes. So the complication, as I show you in the first of our lecture, the complication of diabetes start in pre-diabetes stage. This is in pre-diabetes, we having retinopathy, polyneuropathy, and nephropathy, almost 8% in those patients with retinopathy. And those start to having polyneuropathy, 13 to 11%, especially if associated with impaired glucose tolerance or impaired fasting glucose. And it's reaching up to 17% with those patients with impaired fasting glucose. They start to having nephropathy with microalbuminuria or macroalbuminuria sometimes. As you know, if we more hemoglobin A1C increasing, more start of complications. Here we try to show you hemoglobin A1C 7, 8, 9, 10, 11, and 12. More increase in hemoglobin A1C, more starting of complications. If we intensify it earlier, we prevent the complications. So the question always comes to us as a physicians. Here, all the complications showing in this graph: retinopathy, nephropathy, microalbuminuria, and neuropathy, and progressive retinopathy. Our question comes to us always as a physician: if we decrease only hemoglobin A1C in those patients and we early intensify the treatment, how much we decrease the complications? To be honest with you, it's a huge decreasing in complications. It will decrease 37% in microvascular complication like kidney disease or blindness, 43% in amputation or fatal peripheral blood vessels, 21% decreasing death related to diabetes, 41% decreasing heart attack, and 12% decreasing stroke. And this is only decreasing 1% in hemoglobin A1C. What about if we decreasing 2 or 3? It be rapid decreasing more in complications. So usually we ask ourselves why we delay the intensification of treatment. What's the problem? Where is the problem? Usually there is many factors, either physician related, either patient related, or either healthcare system related. So let us go to the physician related. It's contribute about 50%. So sometimes understanding of patient need for therapy, sometimes failure to set the monitor progressive toward the treatment goals. There is confusing which guidelines to follow and which treatment to follow. Sometimes they said we don't have enough time and resources. Sometimes the problem relating to avoiding the side effect of medication. Some of the medication having severe side effects, so we try to avoid it. What about patient factors? Sometimes there is poor physician-patient communication is a problem. Sometimes side effect of medication is a problem. So inability to follow up is a problem, especially when you start the patient in insulins. Lack of knowledge of disease severity. Sometimes the patient, he don't have enough knowledge about the disease and the problem to it. Sometimes healthcare related problems. There is no clinical guidelines, no visit plan, no decision support, no disease registry, and there is no active outreach to the patient or poor communication between the patient and the healthcare system could be one of the problems. So there is any guidelines to recommend for prevent diabetes or treat? The answer of this, yes. So in ACE guidelines, they're talking about decreasing 5 to 10% of the weight could be prevent diabetes. And in American guidelines, in ADA, they said if you some 7% losing of initial body weight, you will control diabetes. I mean, also the weight reduction, if it's the problem of diabetes, especially type 2 diabetes, 3 to 10% decrease in weight, it will be prevention of enough to be preventive diabetes. And sometimes if we decrease up to 15%, we can say we can reaching up to remission of type 2 diabetes. So now let us talk about what's the medication or how we prevent diabetes or how we control diabetes. According to ACE guidelines, they said, let us start with lifestyle modification and weight reduction, as you know. Then after that we add metformin of the patient. And there is some study talking about GLP-1. If this patient pre-diabetes, you can add for them GLP-1 to decrease weight and can be prevent diabetes or delaying onset of type 2 diabetes. This is the story of management of type 2 diabetes or diabetes in general. general, starting in 1920 with with Canadian professors in 1920 in Toronto University. Then after that, sulfonylurea came, metformin, and TZDs, analogs, GLP-1, DDP4, SGL2, and so on. Nowadays, we have a lot of medication to treating diabetes and to intensify the treatment if we need. So what's the mechanism of action of those medication? As you know, Dr. Nasser Al-Jihani, he talked about sulfonylurea, it's improving insulin secretion, and also we having malignatides, improving also insulin secretion, TZDs, improving insulin resistant and lower hepatic glucose production, metformin also having the same role with reduced intestinal glucose reabsorption, alpha glycosidase inhibitors, also it reduces intestinal glucose reabsorption. It's not used nowadays because of side effect. DDP4 also having improving insulin secretions, lower hepatic glucose production. SGL2 improve insulin secretion, reduce intestinal glucose reabsorption, and having unique rule to reduce renal glucose reabsorption. This is in 2018 guidelines. They should start with, as you know, metformin. Then after 3 months, if not control, add another medication. If not control, triple medication and combination therapy. Consider monotherapy if hemoglobin A1C less than 9, then dual therapy, and injectable. You can start since the beginning if hemoglobin A1C more than 10. This is the guidelines. I think Dr. Nasser, he talked about it regarding if the patient having atherosclerosis disease, start with GLP-1, and if the patient having heart failure, you can start with SGL2, then if not improve, adding GLP-1, and so on. This is all the guidelines. If there is cost issues, you can start with sulfonylurea and TZDs. Okay, this is the ADA guidelines in 2020, which medication you can choose. This is the GLP-1, metformin, SGL2, DDP4, TZD, sulfonylurea, and insulins. This is the efficacy of, they compare all medication efficacy, hypoglycemia, weight change, atherosclerosis benefit, congestive heart failure. This is advantage and disadvantage of each and single medication of the choices. Maybe we'll want to spend a lot of time in it. It's huge schedule, but later on, maybe if anyone can do capture screen or take it by his mobile, then he can choose which is better for his patients. So the potential advantage of area combination, the advantage using of lower dose of individual agent, more rapid achievement of glucose control, and we targeting multiple core defect with complementary mode of action. So you can start with 2 medication at the same time, or if not control, then you add a third one. So you can start with 2 medication area combination therapy. Put in your mind the hypoglycemia effect and hyperglycemia effect, and take in your consideration about the target. There is many factors. There is non-modifiable factor, and there is modifiable factors. Take in your consideration. Yeah, this is the last 2 slides. Okay. So duration of the disease is important, potential risk factors, comorbidities, put it in your mind, vascular complication, and resource and support is very important. As you know, hypoglycemia is a problem. So try to target your disease, try to control it, but prevent hypoglycemia, because this will increase visit to the doctor, increasing emergency visit and hospitalization at the same time. Thank you so much.
Thank you, Dr. Raid, for this excellent presentation. It's my pleasure to introduce our next speaker, Dr. Afaf Shamari. She's an endocrinology consultant at National Guard Hospital, Riyadh. Also, she's assistant professor at King Saud University for Health Science, Riyadh. Also, she's the vice president of Saudi Society of Endocrinology and Metabolism. So today she will give us a talk about risk stratification of patients with type 2 diabetes, interpretation of the latest treatment guidelines. Dr. Afaf, the floor for you.
Thank you very much, Dr. Omar. Thank you very much, Majid. It's my pleasure to be part of this prestigious meeting. And today I'm going to talk about risk stratifications of patients with type 2 diabetes and interpretations of the latest treatment guidelines. I'm glad that two of my colleagues, starting with the management of diabetes, and one is Dr. Nasser, starting with sulfonylurea, the other one is Dr. Raed, talking about the updated management and with the guidelines and new guidelines. I'd like to start with the introduction. The type 2 diabetes is multifactorial and a chronic disease associated with serious complications and comorbidities. And 2014 it was ranked as the 8th leading cause of death worldwide and predicted to increase to the 7th rank in 10 years from now. The patient with type 2 diabetes have an increased morbidity and mortality compared to the general population due to an increased risk of macrovascular disease as well as microvascular complications. I'm going to talk today, tackle just the macrovascular as cardiovascular, one as an example of macrovascular, and with the microvascular as renal disease. So the cardiovascular outcome trials assessing the safety of SGLT2 and GLP-1 as the new modalities that we're having in the market have demonstrated cardiovascular and renal safety and efficacy, which change the diabetes guidelines and improving the clinical practice. These studies have shown that the risk of complication associated with type 2 diabetes can be reduced or delayed among patients with a newly diagnosed type 1 diabetes by initiating and keeping tight glucose and blood pressure control. So the early intervention, the better outcome with decreasing the complications, based on the new trial that we're having in the market now. In the STENO-2 study, patients with type 2 diabetes and microalbuminuria were offered an intensive multifactorial intervention and demonstrated significant reduction in micro and macrovascular disease at 13 years follow-up compared to patients in conventional therapy. So, in order to prevent or delay the onset of complication, it's essential to offer an evidence-based and well-organized diabetes care. The two, I will concentrate on these two, which is the new now, and a lot of studies on the risk assessment being involved in sodium glucose cotransporter 2 inhibitors and glucagon-like peptide GLP-1 receptor agonists have been recognized as recommended therapies for patients with type 2 diabetes and atherosclerosis cardiovascular disease. In the 2020 update, these recommendations have been individualized based on additional comorbidities burden. What are the comorbidities burden? Mainly, we're talking about is if the patient is having, they're diabetic and they're having atherosclerosis cardiovascular disease, or they are having risk factor for atherosclerosis or diabetic kidney disease. And the others is like obesity and other risk factors. So SGLT2 inhibitor to demonstrate cardiovascular benefit are recommended for patients. Anyone with type 2 and cardiovascular or cardiovascular risk factor or diabetic kidney disease to reduce the risk of cardiovascular event and heart failure hospitalization. The GLP-1 as well demonstrate cardiovascular benefit for patients with type 2 and atherosclerosis as well. And this is to reduce the event and especially the MACE. Here, it's very busy, as been showed by Dr. Raed, but I'm going to go with the column quickly before I go and concentrating on these in each column by itself. But the most important thing, when we have a patient coming to the clinic and being diagnosed with diabetes, metformin is still, we have to use it as central sensitizer and with a comprehensive lifestyle, including weight management and physical activity. And then we could recommend, or we could be an add to, if the patient, we divide them, as you can see the column here, the 5 columns. One is atherosclerosis. Is the arrow clear? Is the arrow clear? Yes? Okay.
Yeah, clear.
So as we divide, if we see the patient in the clinic with this, is he having atherosclerosis disease? Is he having heart failure or CKD, chronic kidney disease? Is he having hypoglycemia, frequent hypoglycemia? Is then weight an issue and the cost? And mainly the cost is like private or someone else is not having an access to the governmental hospital. Also now, some of the hospitals, they're not having all the medications available for our patients. So FFF sclerosis, what we're going to do, and with each one, what are the most important to look at, and the tailor the medications according to the patient status. So if we go with a patient, and as actually it didn't change a lot from 2018 till now, with the things is if established cardiovascular disease, and it's the predominant, and then we will go with the GLP-1 or the SGLT2, one of them. And if not reaching the target, we can add. If not, we can consider other treatment, or if GLP-1 cannot be tolerated or stopped for reason another, we can add the DB4. But these are on the top of the management when you have patient is atherosclerosis, active heart disease. If a patient is having heart failure or CKD, and then preferably is to give SGLT2, as all the studies showed is being effective in reducing the heart failure, or the CKDs can be used. If not, we can go with other medications, but we have to avoid TZD because of the volume overload, and with DDB4 is saxagliptin. Otherwise, we can use anything in the market if we're not reaching a hemoglobin A1C target. What about the hypoglycemia? If we have it, is the patient without cardiovascular, we can give anyone. Is HGV1, and we know it's glucose dependent, so we'll not be worried about hypoglycemia. DDB4 can be used, or TZDs can be used, or anyone, but at least to reach a target and with less adverse effect. If there is a weight, so we have, it's like cardiovascular, we have GLP-1 or SGLT2, and if not reaching the target, we will go for second combination or triple treatment, or we add the fourth one. So, but now with what we have now new is oral semaglutide, which is approved in September last year, and is being added as one of the GLP-1 for standard of care. However, we showed it's not inferior in cardiovascular safety, but we need more long-term studies to understand the cardiovascular. I can show you in the next. I will show you in the next. My presentation is the GLP-1 is not a class effect, so there is a difference. That's why with the oral semaglutide we need more studies to make sure that it's been safe on the cardiovascular or have positive effect on cardiovascular. The other thing is liraglutide. As we know, it's been in the market for the last few years. However, it's been approved by FDA in June 2019 for pediatric. That is being recommended if the patient is being in metformin and not reaching the target, and they are more than 10 years. And we have to make in our consideration the family history or personal history of medullary thyroid carcinoma or multiple endocrine neoplasia type. The metformin, we know it's effective. We know it's not causing hypo, and weight change is like modest loss. Atherosclerosis, cardiovascular disease could be potential benefits, but congestive heart failure is neutral. So we left with these GLP-1, SGLT2 as new modalities to modify or to decrease the risk, macro or microvascular. If we go with the trial for the GLP-1, and it's almost 35,000 been involved or studies in this on the GLP-1. They were in GLP-1. The events are around 4,000 plus. So it's having in favor of GLP-1 in general. For the MACE, or the GLP-1 is in favor. So SGLT2 is the same. It's around 20,000 patients, and it is in favor of using it in MACE or decreasing the complications of microvascular. Other risk factor, it's neutral. And when we go with the heart failure this is the difference in GLP-1. We can see here SGLT2 is almost more or less the same effect, the difference percent, but it's in favor, so can be used for congestive heart failure. But when we go with the GLP-1, Alexa is neutral, but leader study with using of liraglutide, which is effective, and Excel is effective. However, it sustains 6, which is semaglutide, was non-negative congestive heart failure. Now we go with microvascular complication with renal endpoint. The sustained doubling of serum creatinine, we're looking the renal endpoint is whether the double creatinine or 40% decline in GFR or end-stage kidney disease or renal death. Here, the GLP-1, you can see is leader is having a positive impact, and XL is positive. That is the SGL2 is all. It can be used with the decline GFR and having improving in the renal function. But if we say SGL2 as in general as having an effect or positive effect or decreasing complications on renal function, but is this GFR dependent or the same for any patients? How it's actually showed the normal GFR, the better outcome. So if we start with GFR more than 90, you can see canvas with canagliflozin, empagliflozin, or with the dapagliflozin. All of them, they're having a positive effect if the GFR more than 90. But if GFR is 60, is actually less effect. So here you can see is SGL2 reduced the risk of progression of renal disease by 45%. The magnitude of benefit varies with the baseline renal function, with lesser reduction in progression of renal disease in patients with more severe kidney disease. So I think is the early intervention a better outcome for those patients considering the renal. We have the Credence study showed patient with type 2 is involved with patient with type 2 with albuminuria, CKD, and being randomized to once daily canagliflozin 100 milligram and or placebo. And the primary outcome for this study is to end-stage kidney disease, dialysis, transplant, or sustained GFR less than 15, doubling of the serum creatinine, or death from renal cardiovascular cause. Results showed the relative risk of primary outcome was 30% lower in Cana group compared to the placebo. Relative risk of the renal specific composite end-stage kidney disease, doubling of creatinine, or death from renal causes was lower by 34%. The Cana group had also lower risk of cardiovascular death, MI, stroke, and heart failure, hospitalization secondary to heart failure. So it showed the effect with the canagliflozin. The empiric is here is showed is really with the MACE, there is a reduction over 48 months. But what about the kidney? Is the kidney, there is a study, is actually they're enrolling, just starting the study, the EMBA kidney with they call it EMBA kidney, the study of the heart and kidney protection with empagliflozin. The primary aim of this study is to investigate the effect of EMBA on the kidney disease.
2 minutes remaining.
Okay, sure. Now I'm finishing. So it's enrolled around 5,000 patients in double blind, and we're waiting for the results. The median is 3.2. So maybe we'll see it in 2 or 3 years, maybe 2022 or 2020. Okay, so the clear cut with this is the all patients with the having cardiovascular disease, GLP-1 and SGL2 can use a second line or even the first line as combination with metformin. The clear role of SGL2 in all patients for cardiovascular or heart failure. The SGL2 is clear for CKD, particularly if the GFR more than 45 milli. But for GLP-1, there is an evidence of heterogeneity for the class, so they are not are the same. Okay, so the conclusion is data from cardiovascular outcome trial assessing the SGL2 and GLP-1 are changing the way of managing type 2 diabetes. Already these data have resulted in new recommendations for the treatment of patients with cardiovascular disease, heart failure, CKDs, and additional data from ongoing trial are likely to whether to reinforce these recommendations or maybe will result in new recommendations. So the new agents are making it possible to treat type 2 and cardiovascular and not just a disease of high blood sugar. Thank you.
Thank you, Dr. Afa, for this excellent presentation. And we'll keep the question after the last presentation. It's my honor to present our next speaker, Dr. Sean Wharton. Are you ready? Yeah, Bismillah ar-Rahman ar-Rahim. Okay, so it's my pleasure to introduce our last speaker for this session, Dr. Sean Wharton. He's an internal medicine specialist He's a professor at McMaster University and York University. Also, he has a diplomat of the American Board of Obesity Medicine. He's working at Wharton Medical Clinic, Hamilton Health Science Center, Ontario, Canada. Dr. Sean will give us a talk about the role of pharmacotherapy in obesity management, weight maintenance, and improving quality of life. So, floor for you.
Okay, terrific. So we'll give 20 minutes. So terrific. So thank you very much. It's really exciting to be presenting at this forum. And really, so what my job today is to talk a little bit about weight management. Where are we in the field of obesity management? I want to talk about the role of the anti-obesity medications in reducing weight, maintaining it, and improving the quality of life. Now, the meeting objectives are going to be to discuss obesity, the prevalence, perceptions, the pathophysiology. We'll look at the challenges in obesity management, and we'll look at the role of anti-obesity medicine in improving a patient's life. So we know at the very start that the entire world has now recognized that obesity is a disease, not just a medical condition, but an actual disease. The same way cancer is a disease, high blood pressure, cardiac conditions. So I think that this is a really important part, because what it tells us is that whenever you see a disease, you think about specific treatments, such as surgery, the use of a medication. These are disease types of treatments. And previously, all we thought about with obesity was looking at an exercise program or a diet program. But when it's a disease, we can look at the use of surgery or the use of medication. So we know that when we look at the number of people living with obesity in the world, there's over 650 million people that are currently living with obesity. And in the overweight category, where we see a lot of cardiovascular disease, there's 1.9 billion people. So, and if we look particularly at the trend of elevated weight that's happened in the Kingdom of Saudi Arabia, we can see that from 1975 to 2016, it continues to go up and up and up. Frequently, the Middle East is not included on the world maps. So when they talk about which country has the highest rate of elevated weight or the highest rate of obesity, we usually talk about America or Mexico. But in fact, the Middle East, Saudi Arabia, and also the United Arab Emirates has frequently had the highest rates of obesity throughout the entire world. So it's a major challenge here. So, and what we found out from the Action.io, now this is a study that actually asked people who are living with obesity their opinion on different topics. They also asked doctors. So when they asked the patient, do you think that obesity is a disease? 68% of people said yes, I believe it is. And 62% of doctors said yes, so kind of close. I'm surprised that the number of doctors saying it was a disease wasn't actually higher. So it seems here that patients think that it's more of a problem. But what is important is that although a lot of people say it is a disease, they don't treat it as one. If you have a disease like breast cancer, you're not going to treat it with diet or exercise. And you may include that, but that's not the primary treatment. The primary treatment for breast cancer is surgery and medications. That's not the way the 68% of people and 62% of people look at this disease. So what we need to do is we need to shift their understanding, not just from the statement that it is a disease, but actual action in terms of treating it as a real medical disease. So we know that there's a lot of different causes of this, and we can see that that it's not just too much food in, and not as much of the activity. There's a lot more actually happening here. So I think that's why it's been such a challenge for us to understand what the treatment options actually are. So we know that there's medical conditions that are caused by elevated weight. And there's over 229 plus comorbidities that affect every organ. And the reason why there's so many comorbidities is because fat cells lead to inflammation. And inflammation is what causes the actual problem. So it's not the fat cell itself, it's the IL-6, the TNF alpha, all of these inflammatory markers. So we know that as your BMI goes up, the prevalence of medical conditions also goes up. So we're looking at coronary heart disease, hypertension, type 2 diabetes, one of the most common connections with weight and diabetes being a problem. So NAFLD, so the fatty liver conditions, another major issue. So, and what we've now found out that obesity is a major risk factor for more severe COVID-19 in patients under the age of 60. If you're over 60, COVID-19 is a major risk factor just because of age. But once you're under 60, the question is why would a patient head into the ICU? So what this study showed us is that when patients are positive with COVID-19, where do they go? They go into the hospital setting versus going home. Do they go home? Do they go to the hospital? Or do they go to the ICU? What we start to see is that patients heading into the hospital, there's a higher rate of elevated weight. And then patients heading into the ICU, again, we see in the bars here that the ratio of patients over less than 60, there's a 1.8 with a BMI between 30 to 34, and heading into the ICU here again, an odds ratio of 3.6. So, and we also know that the severity, once they are in the intensive care unit, the chance of them being intubated is actually higher. So patients with elevated weight, intubation, and sickness from the disease is much, much higher. And that's because of the inflammation that comes from those fat cells. So, and we know that when people try to lose weight, it's very challenging. Why? Because of the metabolic adaptation. If you lose weight, or you lose a pound, or even you start trying to eat better, what happens is this energy gap is caused, and then hunger starts to happen, your expenditure ends up going down. So this is a normal physiologic response. Everybody who loses weight gets hungry. So my patients always ask me, Dr. Wharton, how does the medication work? And it's very simple. When you lose weight, and everyone can decrease the amount of calories a little bit or exercise a little bit more, you end up losing some weight. Everyone who loses weight gets hungry. You don't want to have that hunger. So the medication works by stopping hunger. That has to come normally when you lose weight. That's the way it works. That's the easiest way to have an explanation of it. So what we have seen in the past is that multiple trials will try to have people lose weight with diet and exercise. And everybody loses some amount of weight over the first 6 months, but then after that, we see that over the 4 to 7 year time frame, everybody regains weight. So, and that's because of those metabolic mechanisms. Now, all of these graphs would look significantly different, i.e., the weight would have stayed down if these patients would have had bariatric surgery or had stayed on a medication or had got psychological treatment. So what we see is that the ability to maintain weight loss from the ACTION-IO study, everybody can lose a bit of weight. So globally, they asked patients, were you able to lose 5% of your weight? 38% of them said yes. Then they said at the end of the year, were you still maintaining that 5% weight loss? Only 11% said that they were able to maintain it. Then we looked to the Saudi Arabia data. A lot more people can lose 5% of it, 61%. So everyone's doing okay at the start, but then towards the end, it's really bad. Only 5% of people maintained it. They all regained the weight after the year was over. So, and what we see is that even when we talk about 5% weight loss, 5% weight loss is nice. One, we need to maintain it, but two, we may need even more than 5% weight loss to get our diabetes into remission. 15% to get the blood pressure down in a significant fashion, 15%. And so we can see that for a number of medical conditions, 10 to 15% of weight loss is actually needed. If we're shifting blood sugars, then just going up to the 5% is actually fine. So what type of interventions can we actually do? So this is the 5A study. This is a Canadian-based study where they looked at, can we do a minimal intervention to actually make some changes? Now, what this really stated was that the minimal intervention is asking the patient, is it okay to talk to you about weight management because we have treatment options for you? So that was the minimal part. The advise and the assess, that takes time. So doing weight management takes time. It's not a minimal intervention. But I do believe that starting the conversation is much easier than we previously thought. Patients want us to start this conversation. So when we look at what type of treatment options are available, the main guidelines from the AHH has stated that if your weight is greater than 25 BMI, then doing the simple things and talking to patients about the diet and exercise and trying to get on track. If their weight is going up rapidly or hits over that BMI of 27, that's when we start to look at introducing pharmacotherapy. Once we're over 30, definitely the use of a medication is needed. So between 27 and 30, if you have a comorbidity, then you can use a medication. And then once we get over 35, if you have type 2 diabetes, you can have surgery, and greater than 40, surgery. And I believe that all of these stages here, if weight is a challenge, they should also be introducing psychological treatment, such as cognitive behavioral therapy. So in the Canadian guidelines, there will be 3 main pillars that will help to sustain the diet and exercise. And that is medication, surgery, and psychological intervention, which is cognitive behavioral therapy. So you see, what are the pharmacotherapy options that are available to us? In America, they have a lot more than any other country. But in Europe, you can see that they have a number of medications that are available, but they don't have as much as America does. And in Saudi Arabia, unfortunately, there's even fewer. So this here looks similar to the way Canada is. Actually, Europe and Canada are the same. So right now in Saudi Arabia, you have orlistat and liraglutide. And of those 2 options, there's only one that works in the brain, and the brain is where weight management is controlled. Therefore, there's only one that really works in an effective manner. So as of this time, Saudi Arabia has one effective treatment for weight management when it comes to medication. And we know that this medication works within the brain neurochemistry. So GLP-1 is a hormone in the brain that tells the brain to not be hungry. And we release GLP-1 after we eat food. It comes from the L cells of the small intestines. And unfortunately, people who are living with obesity, that GLP-1 signal is not a loud enough signal. So they don't get enough release of GLP-1 to go to the brain to say stop eating. So they keep on eating. So what do we want to do? Let's just boost up their insufficient GLP-1. The number one way to boost up GLP-1 is gastric bypass and gastric sleeve surgery. That's the number one way to increase GLP-1. The number 2 way is to give GLP-1 in the form of a GLP-1 analog, such as liraglutide. Now, here are the 4 scale trials that looked at using liraglutide in patients for weight management. The majority of the trials were in patients that do not have diabetes, and one of the trials was in patients with diabetes. So, and this here, what I'd like to show you is the weight loss over 1 year in the scale obesity and pre-diabetes study. And we wanted to look at the early responders versus those who did not respond early. So we know whenever anyone takes any medication, Some people do great, just a little bit of the medication, they feel terrific and they do really well. And they start to lose a lot of weight. And these were the early responders. So if you lost greater than 5% in the first 16 weeks, or at least the first 12 weeks after you've gotten up to the highest dose, you were considered an early responder. And you can see that these people over the first year lost about 11.5% of their weight. And these are the people that we would normally keep a medication on. If you gave any other medication for any other medical problem, and after a 3 to 4 month time frame it wasn't working, you would likely stop it. And that's what would happen here in the early non-responders. We see that they were not going to lose all that much weight, but we keep it on in these patients who are going to lose quite a bit of weight. And so, in terms of the categorical weight loss, the early responders had almost 88% of them lost greater than 5% of their weight, greater than 10%, 54.8%, and greater than 15.25%. So that was really positive news. And then if we look at how long would a person who is in the pre-diabetes range progress on to developing actual diabetes. In the placebo arm, you can see that, so we looked at what we have here is data at the 1 year time frame. At 1 year, how many people had developed type 2 diabetes? In the placebo arm, 2% of patients developed type 2 diabetes in the 1 year time frame. If we look at the same timeline for those on liraglutide, it would take 2.7 years. So we can see that results in an 80% reduction in the progression to type 2 diabetes. Now we have to remember that this is a diabetes drug. It's a GLP-1 analog that goes to the pancreas and makes the pancreas respond better. So we expect this medication to decrease blood sugars. So some of the progression from prediabetes into the normal glycemic range is a result of the blood sugar lowering and the anti-glycemic role of this medication. And the other part is due to the actual weight loss as the medication got into the actual brain. So you see here what type of changes do we have in terms of the lipids. We can see that the lipids got better. They all moved in the right direction. And the biggest movements were in the triglyceride arm. This is a weight management trial. If you have a weight management trial and your triglycerides don't go down, then that's not a weight management trial. So clearly the triglycerides had to go down, the VLDL went down, but the LDL didn't go down as much. Why? Because we know that the LDL response is more of a genetic response as opposed to the getting rid of the carbohydrates. And the HDL also ended up going up, which is positive. So if we look at the scale maintenance trial was a great trial, and I presented this data at ECO in 2017. What this looked at was, let's have a patient on a lifestyle modification, because everyone can lose a bit of weight using lifestyle. And there was about a 6% decrease in weight before we started the patient on the medication. This is about the point where the patient has now gotten a lot of hunger because their weight is down and they're about to start to regain weight. At this point, we introduced the medication. Now, what we saw here is we broke up this into the people who responded early, i.e. at the 16-week time frame, did they lose greater than 5% of the weight from where we did the randomization. And of those patients, we saw an extra 10% decrease in weight. So these patients overall had about a 16% decrease in weight, which is significant. The non-responders, you can see here that they did not end up losing a significant amount of weight from the randomization point, but at the very least, they did not regain the weight that they previously lost due to lifestyle modification. So, so next we see that and how many patients in the early responders versus non-early responders were able to maintain their actual body weight. You can see that 91% of patients in the early respond rate did not regain any of that run-in weight.
Dr. Sean,
Yeah.
you have 2 more minutes, please,
Okay.
because we have to be in time for next
Yeah. Okay, absolutely. And we can see here that again, how many patients were regaining the weight? 0 patients had regained any of that weight in the early responders. And these are a number of people that were able to maintain the amount of running weight. So, okay, great. It's okay. It's good. I thought so because we're at 1:22. Okay, well, 1:22 Toronto time. So this is a trial that we did here in Canada, where we looked at the real world effectiveness. So liraglutide works in these scale trials. These are very organized trials where there's phone calls to the patient, they get the medication free. The question is does it work in the real world setting? And what we did was we looked at patients who'd never had bariatric surgery. We looked at 311 patients who were buying the medication, paying for it, and taking it on a daily basis. We divided that up into patients who stayed on the medications for 4 months. And so you can see it went from 311 down to 210. So 101 patients stopped using the medication in that 4-month time frame, but 210 stayed on it. And that's really good. So and here we see that over the 6-month time frame, that 53.7% of people were still on the medication. Now, this is a big deal. What we usually see is that when people start a weight loss medication, about 80% of those people will stop the medication over the 6-month time frame. 80% stop. So only 20% are still on the actual medication. Here, we saw that 53.7% are still on the medication, indicating that the medication is working. There's no reason to stay on the medication unless it's working. So we saw a significant amount of weight loss here as well. At the 4-month time frame, we saw 6.9 kilos in terms of decrease in weight. When we went out to 6 months, we saw it went down to 8.1 kilos, which is very similar to the amount of weight loss we saw in the actual scale trials. So real life is mimicking the scale trials. And then we looked at how many people lost greater than 5% or lost greater than 10%. At 4 months, we saw 62.6 lost greater than 5, and greater than 10, it was 18.2%. Now let's move to the 6-month follow-up. If you stayed on the medication for 6 months, the number of people that lost greater than 10% went up from 18.2% to 35.2. So double the amount of people were able to get to that 10% weight loss. Remember at the beginning, we talked about the fact that you need 10% weight loss to see a number of significant changes. So we're seeing that over a third of patients were able to maintain that in the real life setting. So what type of side effect did people get? The number one side effect was nausea over all of the actual trials. So the GI side effects. And so those were the main things, and we saw that within the real world setting also. But when it comes to the nausea, we know that the nausea goes away after the first couple of weeks. So it significantly decreases. So I tell all my patients, let's take it easy. You'll get a bit of nausea, but it's going to get better. And then in terms of the other side effects, so as stated, the GI side effects were the most common. There were some occurrences of pancreatitis, but it's rare. And in fact, and then it makes sense. GLP-1 goes to the pancreas. If your pancreas doesn't like that molecule, then you'll get an acute reaction, but you stop the medication and the reaction goes away. So we don't worry about the pancreatitis because it's so rare. The breast neoplasms, there were some increased number of patients that stated that they had a breast cancer, but we believe that those about 10 patients it was mainly because those patients lost weight. They were able to detect the actual breast lump. So that is a detection bias. So we don't have a concern because there's no GLP-1 receptors in the breast tissue. So patients, it's not a concerning thing. In terms of the medullary thyroid cancers, there were 0 events. So medullary thyroid cancer happens in rats. So that was where we saw it, but we don't see it in actual humans. To see it and in terms of MACE, there was not an increased risk of MACE. And in fact, liraglutide has been shown to be protective to the heart. So that's positive. And there were no neuropsychiatric challenges either. So in summary, obesity we know is prevalent and it's poorly managed in KSA. And as stated before, the amount of obesity in the Middle East and in Saudi and within the UAE is significantly higher than most other countries in the entire world. So we know that weight regain is common. Everyone can lose weight, but people can't keep it off. And that's why we need to introduce better treatments. So weight management medications work within the brain neurochemistry. We know that liraglutide is effective in weight loss, not just in the randomized controlled trial, but also, as I showed you, in the real world data. We know that if you have an early responder, those are the people that are doing great from the very outset. They will continue to lose a significant amount of weight. And those are the people that we want to stay on the medication. And finally, we know that the serious adverse effects with liraglutide were actually rare. The most common were the simple adverse effects, which was the nausea, which ends up getting better after a number of weeks. So thank you very much for your time, and we'll be here to answer questions as we move forward.
Okay, excellent. Thank you, Dr. Sean, for this excellent presentation. You were in time. Thank you so much.
So and, as well, the last slide, I should probably say that about the Medscape and the scope, and you guys are going to be mentioning that.
Okay. Thank you so much. Okay, now, so please, all the speakers stay in the line. I have a question already handed to me. First question is for Dr. Raid. Can you? Okay, so Dr. Raid, there is a question. In patient with 45-year-old newly diagnosed type 2 diabetes with average body weight with repeated A1C between 9 to 10, what is your best starting regimen?
Usually in this patient, if it's obese and having recently diabetes, I think the GLP-1 is one of the choices, can be used for them. If not controlling GLP-1, we can add for them SGL2. Then we'll go from there. Metformin also can be started as a first option. Then GLP-1 can be added. Then SGL2, if not controlled, to be added again. But GLP-1 definitely for overweight or obese people, it's one of the choices.
So part two of this question, what are the methods of intensification and follow-up?
Again, what's the question?
What are the methods if you want to intensify? So your next step is?
Yeah, I can start for this patient with metformin and GLP-1 as a first step. Then if not control, I will add SGL2. It will help to control diabetes, and at the same time, it might also decreasing weight extra.
Okay, thank you so much. Next question to Dr. Nasser. Patient in chronic liver disease, what is your best oral antihypoglycemic drug? In cirrhosis patient also, what is the best drug in diabetic patient? The part two of this question, can be metformin used in chronic liver disease?
Yeah, I will talk about sulfonylurea, but anyway, in severe chronic liver disease, I think the best treatment is insulin. Okay, regarding sulfonylurea, better to avoid in moderate to severe chronic liver disease.
Okay, so what is your best choice for chronic liver disease? As I am online now with the person who's asking. So your choice is?
Yeah, regarding I am talking today about sulfonylurea, but I think severe, if class C, probably insulin, okay, is the best. I don't know if Dr. Raid want to do comment regarding chronic liver disease or hypoglycemic, because he reviewed the subject, but in severe chronic liver disease, probably is insulin is the best.
Okay. Next question to Dr. Afaf. As most our concern in diabetes sometimes is obesity or weight gain. So sometimes patient need weight gain is from our own medication, like sulfonylurea TZDs. So what is your input in this? So it's I
Thank
guess
you.
it's regarding the medication that can cause weight gain.
Yeah, thank you for the question. Is actually is the according to the guidelines, we put the weight as one of the columns, the major columns. If the weight is concerned, is metformin is good because modest reduction of the and you can treat diabetes and weight. So modest reduction or at least neutral. The second thing is that I think GLP-1 can be effective and as well as SGL2. SGL2 with these studies is around 4 to 5 kilograms. So I think these two. We try 3. We try to avoid TZD because it's weight gain and fluid retention. Sulfonylureas is no, but DD4 could be neutral. Okay, so can be used if the others were not reaching the target. So we start with metformin. Second line for me is to give GLP-1. If no contraindications, we can give, or the patient does not prefer to get the injection until we get semaglutide orally, or SGL2 tablet. If not reaching the target, we can add DD4 as long as the patient is not in GLP-1. If not, so we will just ignore that. Not ignore, but we have, as all the time, we're stressing on the life modifications, is the diet and exercise, carb counting, all this, if the patient is going well, rather than adverse effect, because we're blaming the drugs. But one of the things is, should the patient look after their diet and doing regular exercise, to make sure that not to gain weight, not to blame all the time as the medication.
Okay, thank you so much. Dr. Sean, 3 questions for you. Get ready. So first question from Dr. Ashraf. Thank you, Prof. Sean. How can we explain the contradiction of keto diet, weight reduction, and the use of orlistat?
How can we explain the contradiction between ketogenic diet?
Yeah, and the use of orlistat medication.
Oh, okay. So I didn't know that there was, I'm not aware of a contraindication between using those two dietary, doing the ketogenic diet and using orlistat. So my opinion.
Contraindication is the contradiction.
Contradiction. Oh, okay. So why are you losing weight on the ketogenic diet when the ketogenic diet is a low carb, high protein, and a high fat diet? How can you, and the orlistat is a medication that causes a loss of fat. So that's a contradiction. I certainly understand that. Okay. So first of all, the orlistat, you only lose 30% of the actual fat. So 30% stays within the bowels, and then it is expelled after that. There's still 70% of the fat that ends up coming into the actual system. So that's, and really orlistat does not work very well in a high carbohydrate-based diet. So it only really works in a high-fat diet, and it's mainly when those high fats are bad fats, right? If you're having good fats, the Mediterranean fats or fat from fish or omega-3s, then there's no reason to take orlistat because it's getting rid of some of those good fats that may be helping you with your overall health status. So I don't recommend orlistat almost ever unless someone has constipation and they need to be helped with their constipation. That's the only time I recommend a bit of orlistat, and they can take it once a week or twice a week whenever they need it. But otherwise, it doesn't do anything really positive in the setting that we have now, today's setting. Maybe back 15, 20 years ago, but it doesn't do it now.
Okay, second question. What do you think about using metformin in somebody who is not diabetic and with BMI more than 31?
Yes, I do not think it works. So metformin does not work to decrease weight in somebody who does not have diabetes.
Or pre-diabetes, yeah.
And if they have pre-diabetes, it may decrease the weight a little bit. It certainly doesn't make the weight go up, may go down a little bit, and it'll bring the sugars down. So metformin is going to open up the muscle cells and allow energy and insulin to go into the muscle cells. So very positive. So I actually really, really like it. But we do use metformin in patients who are on antipsychotic medications. So it does decrease the weight from about 3 to 5 kilos. And so these are patients that do not have diabetes, do not have pre-diabetes, or they may have pre-diabetes, it doesn't really matter, but are on antipsychotic medications. We use it all the time in those patients. We've kind of extended it a bit into people who are on antidepressants. So the study wasn't with antidepressants, the study was with antipsychotic medication, but we extended it into that, and we do it a lot, because the antidepressants are causing some weight gain, so we put the actual metformin on, and it seems to benefit patients very nicely.
That question, what is the max from Hala Al-Shafi? Okay, what is the maximum period to achieve weight loss with liraglutide, and for how long we can safely use it? For how long we can safely use it?
Okay, so I think that's probably the most important question. So the number one question I get from all my patients isn't how much does it cost, how many side effects. The number one question I get is how long do I have to take it? And the reason why people have that question is because of bias. The world has been filled with bias that just diet and exercise is enough to decrease weight. They wouldn't say how long do I have to take this medication if they had congestive heart failure. They would say, congestive heart failure is a bad thing. I need to take this probably for a long time. That's the same thing here. But I don't answer that question with you have to take it forever. That's a very bad answer. So everybody out there, anybody asks you, how long do I have to take this medication for? The wrong answer is I have to take it for, you have to take it for a actual lifetime. And that's probably true, but that's the wrong answer to the patient. The right answer is, I don't know how long you have to take it for. Take it for as long as you want. Take it for, if it makes you feel good, take it for 6 weeks, for 6 months, for 6 years. I don't know. All I know is that I want to help you to the best that I can. This medication will help, and I'm sure that you will enjoy it, and let's just start it. I don't know how long. Now, the question of whether you're going to regain the weight when you stop the medication, if you didn't make any changes, didn't change the way you eat with your family, didn't change the way you organize your actual life and your eating, then of course you'll regain all the weight. If you make those changes while you're on the medication, make the changes while you're on the medication, you have a chance of keeping the weight off if you stop it. So that's what you tell your patient, and then they're happy and they're hopeful and they'll start the medication. Don't tell them you're staying on this forever.
Thank you. Excellent. So I think we are in time. We don't have any more time for any question. I want to thank all the speakers for your time. Thank you again, all of you, Dr. Nasser, Dr. Afaf, Dr. Raid, and Dr. Shuan. Thank you so much.
Thank you very much. It was great. I really appreciate it.